You're live. This is Senate Appropriations, and we're continuing our work on the FY24 budget. And we're now hearing the budget request from the Department of Mental Health, and we have the commissioner here. And we have Shannon Thompson, and is that it, Shannon?
Yeah.
And
Nicole Tessati.
okay, you're not on the sheet here, so. And so why don't we get started? I gather this would be the document that you want to work from. All right. So why don't we let you present? As you know, this committee, we don't want to go through all your, fee for space and digital services. We really want to focus on kind of the high points of your budget presentation. We probably won't hold to the script anyway. So why don't you start?
Sure.
With what you, maybe certainly the highlights here.
Sure. For the record, Emily Haas, Commissioner for the Department of Mental Health. And with me today is Shannon Thompson, our Finance Director, and Nicole D'Estasio, our Policy Director for the Department of Mental Health. So I could go through our large visioning, which I might just re-highlight. I know I've presented this for this group historically, but all of our policy initiatives and the department's vision come out of some work that we did with key stakeholders right before the pandemic in 2020. And so it is referred to as Vision 2030. It highlights services that you see in this year's FY24 budget related to our mobile crisis initiatives, our peer certification and credentialing, and more integration with mental health and substance use. So I just wanted to highlight that. A reminder, we oversee our designated agency system. So that is 10 designated agencies, 2 specialized service agencies, and 7 designated hospitals. We also operate the Vermont Psychiatric Care Hospital, which is a 25-bed hospital located here in Berlin, and the Middlesex Therapeutic Community Residence, which is currently in Middlesex, soon to be Essex, and growing to a 16-bed residential facility. And then as a department, we have around 253 staff at our facilities, and then about 60 central office staff when we're fully staffed. Here's a snapshot of our system. So our designated agencies run adult crisis beds. There's 38 adult crisis beds, 18 youth crisis beds, and then 42 adult intensive residential. So serving the longer term needs for individuals who may need that. Our designated hospitals have 3 different types of units, with the Brattleboro Retreat being the only facility that serves youth. From the adult perspective, we have 2 levels of care, a level 1 bed, which is often referred to as the beds at Vermont Psychiatric Care Hospital, a subset of beds at Rutland Regional, and also a subset of beds at the Brattleboro Retreat. Those are for folks who need additional resources in order to get the adequate care that they need to
So
recover.
Linden Lodge is operational now because there was a delay because of staffing.
There was a delay. It is operational now. I can't tell you off the top of my head how many admissions they have there, but they were maybe at 10 the last time I checked. And then as a, so there's 57 of those total. And then our non-level 1, so our general hospital beds, psychiatric hospital beds are about 142. And those serve primarily folks who are voluntary, as well as, depending on someone's needs, there are some involuntary folks who can receive treatment at that level. We also fund peer service agencies. They operate 2 crisis beds for adults and 5 adult intensive residential. Any questions on this, the system overview? Great. We'll move on into the 24 budget. Thank you.
Okay, this is a summary of our budget request. The total governor's budget recommended for mental health is $310,613,893. This chart here shows you what percent is Medicaid versus special funds, which includes Medicare funds, interdepartmental transfers, federal funds, and general funds.
So what would be your federal funds that are other than the Medicaid, which obviously is a big chunk?
The federal funds
Yeah.
consist mainly of mental health block grant. We do
SAMHSA.
have some SAMHSA, we do have some other SAMHSA grants that we're working on as well around children's.
One of the things that I've heard is that SAMHSA is kind of working in their own silo. I hate the word silo relative to mental health and treatment. And then you've got HRSA with the FQHCs, and they're just funding another initiative. And then we have the proposal with Blueprint, and then we have our core mental health delivery system. And so there's obviously a lot of things happening in parallel. So how are they coming together? One of the concerns I would have is that the DAs were put in place to replace the institutional settings. And therefore, there was a safety net to make sure that our, but they're also usually the sickest. They come with more difficulty, more complex situations. And so we've talked about the integration of mental health and physical health, which is really good. But the question ultimately becomes one of where funding is being directed and whether we in fact have a system that is designed to serve the most costly, the most acute, the most persistent, seriously mentally ill that is over here, and the extent to which that work becomes complementary or competitive in the sense that all the difficult patients flow to this rather fragile and, to be honest, a bit underfunded part of our healthcare delivery system, and all these other initiatives that are designed to provide the care at a different level and certainly a different acuity. So I'm just wondering what your thinking is in terms of how all those funding initiatives come together in a way that don't further weaken our current community-based system.
And I think that's a really good question. So our designated, it's something we should all be thinking about, right? Across healthcare in general.
Right.
I think from when I think of core services, I think of services that are mandated. So our designated agencies are mandated to serve folks who are in community rehabilitation and treatment programs, as well as the emergency services programs, and then children, youth, and family. And outside of those services, I think there are some core services that our designated agencies also do in regards to adult outpatient. Some folks are doing delivery services in coordination with Department of Corrections. Some agencies are co-occurring and are also preferred providers in the substance use system. And so from my lens, what we're trying to do is to offer an opportunity for folks to get care when and where they need it, knowing that there's also folks who aren't necessarily at the high end of treatment need who also need supports. And so when we look at our system, we're looking at gaps. And when we look at our data, we're seeing the programs for CRT or community rehabilitation they're on the decline of folks who are engaging in that program. We're also seeing a decline with children and youth services, but we're seeing a very sharp increase in emergency services. And so that's why you see us targeting those more upstream services so that we can then have folks entering CRT who really need it. Not that they're not entering that now, but I think there's some earlier interventions that we could do so that folks don't get to that point if at all possible.
Well, that's certainly the point, with all that we funded through Medicaid with our schools, you know.
Absolutely, absolutely.
But, so anyway, you usually get some cross subsidization, the same thing we're getting with our childcare. If you pull off the 4-year-olds that don't require the same level of care and only have infant and toddler that are more expensive, and you keep the rates the same, you have no ability to cross subsidize or share the burden. And so I think we have to be really careful that, you know, that in our integration efforts that, and then in this case, we're proposing to increase reimbursement for all parts of the provider system, unlike mental health, where we're level funding a very large system. Actually, the number of employees in the DAs and SSAs exceed the state workforce.
That's correct.
And so it would be like the governor saying, I'm not funding, I'm going to keep government level funded. And you manage the money.
Mhm.
And so needless to say, we're hearing from those systems, and we had our hearing, and they're asking obviously for an additional increase because of all the reasons you have here for ops, and that is inflation to operate these facilities. So those costs are going up. And then of course they're competing for workforce, and frankly, they're fearful that we're going to see the same thing, and that is rating the best staff that we have in those organizations to go into maybe a more preferential, less intensive, less difficult part of the mental health system. So that's why, if you're anticipating what those potential collateral impacts might be, it's with that, I think we've got to be quite careful that we recognize that we might be adding more rooms on a, as I've said, a house that doesn't have a very good foundation.
So can I
Go
just,
ahead.
so I'll just give you examples that I know
Sure.
of. And so in my county, our mental health agency's got about 220 employees. In the schools, my larger schools are now all hiring mental health workers on their own, but it's only in the larger schools. In a lot of the smaller schools, they've contracted with Lamoille County Mental Health, and they're out harder to serve, less kids, and more running around, and are more, it's way more cost effective in the larger schools. But the contracts that my mental health agency had with the larger schools, they're beginning to lose. I've got an FQHC that I can't remember, but it's at least 2 and maybe 3 that they're hiring right now. They get the higher Medicaid reimbursement because they're an FQHC, and they're beginning to pick off things that they get the higher reimbursement for and are easier things to serve than my mental health agency. So, and there's a couple of other areas I've heard of stuff, but those are the 2 areas that I know of the best. So it highlights exactly what the chair is saying. And we're sitting back doing nothing.
And yet we heard from the, Commissioner of Health about the importance of mental health in terms of overall health and so forth. So we're represented, and you're not responsible for the budget that's being sent for us, but we can express our concerns around how funding decisions actually either help or make no, or don't even seem to show much recognition for those other areas of investment in healthcare. So we'll obviously be looking at that, but we did have a request, and we also had the request, which we know is an issue, and that's the disparity among reimbursement and rates by agency. And we know that that's complicated because oftentimes we've asked an agency to do something and we'll say, and we'll pay you through your rates.
Mm-hmm.
So comparison from one to another, you can't do because it doesn't show you underneath why that rate might have been adjusted to accommodate some additional activity or program or whatever. And so the day we voted out the BAA, we got a request from Vermont care partners for, I don't know, over $1.2 million or something to fund that rate disparity, which I gather there's probably some disparity, but you've got to be really careful in how that's approached. And so I'm just letting you know what we're getting on
Yeah.
our end in terms of what is desired. Now, of course, we also have level funding for residential care facilities, enhanced, ERC, for choices for care, for all our youth service bureau, and the list goes on. And all of those, and some of those activities are really more upstream, like youth, oftentimes, youth services will intervene or whatever. So we're sitting here with some significant budget issues and understanding that decisions we make in one place, how they do or don't,
I mean, I think that weighs
or
heavily on all of us.
undermine.
Yeah.
So I know what it is, but we just need to share with you the kind of impact and information we're getting. And so I don't know at this point what the budget's going to look like, but I suspect that the reason we could find 56 million for a childcare initiative is by making these decisions around what we didn't fund. And so that is going to be all part of the work ahead of us.
Sure.
Senator Lyons has a comment on Zoom.
Okay, I don't see her on the.
I'm here. I'm here.
All right, Senator Lyons, do you want to raise your question?
Yeah, thank you. I do have a question. I'm not going to turn my video on just yet because I don't know what it's going to look like. But Commissioner Hawes, thanks for being here. I do have a question regarding the Act 197 initiative that we put in place last year, the grant funding that we had for kids in schools and a part of somewhat of the after school program, and additionally support for teachers around mental health, knowing that it continues to be a crisis. But are you seeing any outcomes, beneficial work that's going on as a result of investing those $3 million into the mental health prevention services in schools? And I don't see it in the budget. I don't see a continuation. So if you could talk to those two things, maybe the outcomes and then the potential for continuing those programs.
Yes, sure. So that is in collaboration with our partners at the Agency of Education. So I think they could talk more succinctly about the data components related to that. We worked closely with our partners over there to develop an RFP for supports for educators. But we'd have to.
But it was also for kids. I mean, it was from the very most basic level of support services to psychotherapy through grants funding. So I'm wondering if you've sent these grants out, and then have you seen any return on that, or if that's still coming? Obviously, I know it's a short period of time, but.
Yeah, I would say it's still coming, but like I said, our partners at AOE have really led that with us in consultation. So I'm happy to connect with them and have us all come back.
Maybe that's a good question when education comes in, Senator Lyons, as well.
Yeah, that would be good. And I did talk with Heather Boucher yesterday. So.
Oh, great. She's been our lead with Laurel Homeland.
Okay, that's helpful. But just thinking about the benefit of this as being way upstream and putting in place some programs that, should they continue, might continue to be a huge return on a small investment.
Well, that's part of the Children's Integrated Services, is really a replacement for the old COPS, which is Children's Upstream Services. So it probably is a good idea. All we hear about is the additional need. Okay. And it's really, the question really is one of, when we've made these investments, how do we have some sense, did it
Yeah,
matter? Did it, did it bring about improvement? So I think that's kind of the heart of the question. And it's not only here, it's with housing, we put millions and millions of dollars out. And the question ultimately would be, what has been, the result as, from the funding? So
that sounds like a gap on our end. We want to make sure that you're aware of the impact of the decisions that you're making. And so what we could do is bring back our child and family unit so that they'll be the content experts and can probably answer your more specific questions better.
I may
than
have
I
to
could.
defer to our chair of health and welfare to do that.
Yeah, okay.
Well, we will do that. Thank you so much.
Yes, that's been helpful. I think another testimony this year is getting an update on those initiatives and how they've supported our communities.
So you have some budget initiatives.
We do.
Okay. And I can see peer support. Well, we passed the bill last year on peer.
Yeah, you passed legislation related to the working group. And so that's what's happened over the last year. And this is taking the recommendations from that working group and putting that into
We passed legislation last year. We didn't? There was a bill, I remember.
There was a bill, but there was
No,
not.
yeah, so the bill didn't pass, but the idea of peer support credentialing did.
Didn't we
And
put that in the budget then or something?
I
know
thought,
we did something on it.
I don't know, I can't remember what we had in the budget. I know that we were hoping for some peer support services overall in the state, including possible beds or housing.
Yeah.
But yeah, that's probably an important next step.
What ends up surviving through the process.
Yeah.
Yeah.
So why don't we go through, obviously your ups and are pretty straightforward, and some of them actually tie back to a budget adjustment, like the micro residential in
Yes,
Washington
correct.
County, and
Yep.
some of the internal service funds, et cetera, positions. So rate adjustments. So I guess why don't we go to the initiatives? I think that might be a good part on this sheet. It's the budget summary, and it's got the ups and downs, which are pretty self-explanatory. But then 911 is certainly a new initiative. We all have to dial our area code.
988, yes.
Yeah, but I understand that the at least the experience to date has been that there's been fairly strong use of that resource.
Yes.
And so
That is accurate. They, I think they almost tripled the amount of volume of calls that the call centers were
and there are two
answering. There's two call centers, one with Northwestern Counseling Center and the other with Northeast Kingdom Human Services. And then if they aren't able to answer a call that comes in, it kicks over to an entity in New Hampshire.
And so the number of calls you said it tripled.
I believe they've tripled. Usually Deputy Commissioner Crump talks more succinctly about our 988 data than I can. But I believe that's in general the increased call volume.
So the increases to 988 would be to add more staff, or exactly?
It's to keep up with that call volume that's continued to grow. Yes.
And so that would be to fund more positions, right? To answer the what's your increases to 988 activities? What is your up there? What are you funding?
It's for that, and it's also for some chat and text. We're getting into the chat and text.
Is that all under suicide prevention?
We are, so are you looking at the next
Yeah.
chart? Yes, that is incorporated suicide prevention piece.
So you have a mobile crisis response expansion.
We do. So we were given money last year to expand mobile crisis to 5 regions. And now we would like to expand that for statewide. The Mobile Crisis Response Initiative includes a couple of things. It includes physicians within the Department of Mental Health to oversee the project, and then it includes the expansion for the statewide initiative.
We expanded before the Rutland pilot even got operational, right?
No, the Rutland pilot was operational in October of 21. That came out of legislation from the, I think, 2021 session. So they're a little over a year active. The Rutland pilots.
I guess maybe last year when we were doing it,
Yeah.
they just barely started then.
Yeah, and I think there's also a timing confusion with Mobile Crisis and the Rutland pilot project. So the Rutland pilot project was implemented prior to the feds releasing the higher Medicaid match rate for mobile.
Yeah, I
crisis.
remember we put in some language
Yeah.
anticipating that. now.
So we had to shift that match, the activities under that match, balancing the work that our friends at Rutland Mental Health have been doing in that pilot. So with the mobile crisis response under the new federal match, it requires a 24/7 response. It requires that response to be a 2-person team, and it requires them to meet folks in the community. If the service is delivered at an emergency room, it doesn't qualify for that rate. And we did that, we began moving towards that program delivery because we know that our communities were needing to get access in the community when and where they are versus navigating a trip to the emergency department. And so this mobile crisis program really helps us do that. In some states, they connect mobile crisis with 988. And so theoretically, you may see us come back and talk about how 988 dispatches a mobile crisis team.
Well, the other thing that we did, Senator Ash was here at the time, and that was to embed a mental health worker and with law enforcement.
Yes. Yeah.
Because we were getting testimony that I don't remember a large percentage of their call outs, in fact, were mental health, not law enforcement. And I'm just wondering then, what is the relationship between if the call comes into through law enforcement, which oftentimes that's what people call, then what is the nexus with the mobile crisis response?
Sure. So the law enforcement folks could dispatch mobile crisis. It's helpful to know that the embedded workers with law enforcement isn't 24/7. It's about 40 hours a week, and so that doesn't serve round the clock. And so we anticipate a close connection between those, because there will be times when it doesn't make sense for the social worker to go out with law enforcement to meet somebody in the community, but it would make sense for mobile.
And there are times when, in fact, the family would call and law enforcement
Right. Yes.
doesn't have a presence.
And we have developed a nice crosswalk that outlines the differences in the types of response that communities have. Not all communities have, say, street outreach. Not all communities have an embedded law enforcement or worker within law enforcement. All communities do have emergency services with their designated agencies. And so we do have a nice crosswalk to talk about who's calling each of those different programs and how they connect across the system, which we're happy to share if that's helpful.
So that would make it a statewide. Actually, you think about it, it should be inherent in our delivery system. It's just like any other part of healthcare. You have another kind of medical emergency, you have some ability for 24/7. It's not all based on doctor's offices, appointments, and generally it's weekends and evenings. And so it's interesting that we're just getting to do this now. I guess is my point, is it seems like it should have been just part of how we deliver services and recognizing when individuals have a crisis and how the system is designed to respond.
Mhm.
It seems only recently.
You can't have your crisis unless you've made an
I know,
appointment.
yeah.
I think that's the answer.
Well, it seems a recent realization that mental health is healthcare.
Mhm.
That's kind of,
Well,
like
that's
it
true.
was totally separate.
Yes, and we still have a lot of work to do with that. I mean, from my perspective, the pandemic has provided some not so great things and some great things. And from my lens, the conversation about folks who have mental health and substance use challenges and physical health, it's our neighbors, it's ourselves, it's everyone. And I think COVID was an opportunity for folks to sort of understand that on a different level than our communities have understood it historically. And we want people to ask for help and to, yeah.
I think the highlight of that is the conversation we just had about the monitoring of services. If it was in healthcare, it would have a CON process. Even if you're or if you're a home health agency, you have a CON process, and you don't allow privates to come in and pick off the easy cases to do that. Mental health is totally outside of that.
I will say with the mobile crisis response initiative, it's required that the staff can respond to both mental health and substance use crisis. Our designated agency system, I think 8 of the 10 designated agencies are preferred providers under the substance use preferred provider system, and 2 are not. So that's, there's an opportunity for improvement in that crisis response too, that we can really enhance the skills of our responders in being able to serve
So
both
what
of those.
where we have mobile crisis as a result of last year, we added more. So where are the response, where do we have it now, and where do we not have it, and this would get us?
Sure. So we haven't had an opportunity to roll out from last year yet due to the shifts that we had to make to come into compliance with the requirements for the enhanced match. So we engaged in a contract with Health Management Associates, who helped us and the broader Agency of Human Services analyze our system in order to put together a mobile crisis response program. That includes manual development, that includes quality analytics, so on and so forth. So our timeline is a September rollout. We just posted the RFP and that closed maybe about a month ago, and so we're working on notification of
So
the
where do
winning
we
bid.
have mobile crisis right now?
We do not have an operational mobile crisis right now that meets the definition of what's being proposed
To
here.
meet the federal.
Correct. And there are some parameters around that, so it goes until March of 2027, and there's a 12-quarter timeline. So once you start operationalizing the mobile crisis, you have 12 quarters to utilize that benefit. And so we want to time the rollout with that.
But federal participation is limited, or the match incentive is time limited?
It is time limited. That's the 12 quarters or March 2027.
And it's in the form of a higher match, or is it?
It is, it's an 85%. Am I right on
That's
that?
correct.
Oof.
85% match.
All right, well, if you're still around here, Stephanie, there's another thing on the cash register when the match goes down. All right, so we have 85 for that. We still have 90-10, I think, for family planning. So we have higher match rate for SCHIP. We've got different match rates for everything, I guess. All right, then you have therapeutic alternatives to the emergency department in the Northeast Kingdom.
Yes, thank you. So this was an initiative that began in the Northeast Kingdom. They'd like to, and we'd like to support them with putting together a living room model, which is an opportunity for someone to seek short-term crisis stabilization services without needing to engage with an emergency department. So let's say somebody calls 988 dispatches mobile crisis. Mobile crisis then utilizes a program like this living room program.
Would this be available for adolescents?
I think it is across the age span. Yes,
Because, you know,
I believe it's across the age.
I had a woman call me, and her niece actually was, and really needed to have, she said she just needed to have an opportunity to kind of have and she said a few days in some kind of a residential, and in the end, the Youth Service Bureau helped, but they kept her in the hospital longer than necessary because she wasn't ready to go back home in that environment. And so I was just wondering, it brought home adult, you know.
I believe it's across the age span.
Okay, all right. Now, is that, what I'm intrigued by is the state match is only a little less than 700,000, but the gross for that project is 2.3, which makes me believe it's Medicaid. But then I've been told that if there's a need to acquire a building, there's funding for capital. So I was hoping you might be able to clarify exactly what we're buying here in this budget.
Yes. Do you want to talk about the line items, and then I can talk a little bit about the
Because you
capital?
can't use Medicaid for capital.
Correct.
Right, so what's in the budget, the 1,588,229, that's Medicaid, but of course it has a general fund match. So the general funds that you're seeing, I think in the language, is just what the general fund match is on that Medicaid.
And the global commitment. Is it a global commitment there?
Correct, yes, yes. And then there's the separate request for the capital.
And where is that request?
That request is outside of this because it falls under some existing federal funds that were set aside for capital projects. And so that's,
You don't need an appropriation for that?
I don't think so.
No, it's you probably heard HCBS,
Yeah.
community-based FEMA, enhanced FEMA.
And we can do capital under that?
There is a section for capital. It's a different match rate, but there is a section for capital.
Okay.
Or it's
So-
not matched.
But you have to match it. So is the match request here?
It's not necessary to be in here, from what I understand.
So,
Yes.
and Rich Donahue, CFO for AHS. So all of the funding that is eligible for capital under federally approved HCBS uses is already appropriated in one-time
Oh, we did
state
that, yeah.
appropriations.
All right.
Thank you.
You're welcome.
All right, I guess, so I remember we approved that and we've been doing some increases out of it. I didn't realize we could do capital acquisition.
A small scale
Mm-hmm.
of funding is allowed for that.
So how much?
I think it's approximately 6 million.
6 million? All right, yeah, well, we did approve the plan and we've been, may have used up quite a bit of that capacity, haven't we? All of it.
That's what you had at the beginning of the session from Wendy and Tracy.
Did it include this? It did?
I mean, it wasn't probably this project, but the subject, you know,
Oh.
the headers of it.
Well, that's another area that match is gonna go down. So keep that on your list too, Stephanie. Okay, and then we've got some downs. Those are pretty straightforward. We are a little concerned. I imagine the CRT population, and we talked about that yesterday with Eva, and that is if we don't adjust those caps, the higher rates mean, in essence, we're gonna pay the dentist more, but we can only buy fewer services. And I know sometimes the management of those patients and dental practices is a challenge. So we hope that it will assure greater access, but in the end, if we don't deal with the caps, it might mean less care. So we did talk about that yesterday. And then we've got just movement between DCF for NFI and
No, sorry,
Yes.
this is in your way.
Oh, that's
There
okay.
it is.
It's okay. Yes, if you'd like to talk about that.
Is there a rate increase for NFI?
Was there a rating?
Yeah.
So the NFI, I'm just gonna pull that out here. Let's see.
Is Charles Myers still the director?
Jack
Yes,
Myers is still the
yes.
director, yes.
Oh, good, I have his card right here.
That's handy.
I'm amazed, isn't it amazing what I can, all right, so he's,
Yeah, the movement of funding for NFI is because we pulled out the room and board. We pulled out the room and board out of their case rate. We realized there was some room and board in their case rate, and we have to pay for that with general fund. So that's a shared activity with DCF, so we have to send funding to DCF for that, to cover their portion of the room and board.
and then we've got the Washington County micro residential.
The Washington
What's the spelling
County.
of residential?
Oh, was it that?
Oh, did I misspell residential?
Yeah.
It's not that bad. Oh, boy. Put the I in the wrong place, of course. That's to increase salaries for staff at the micro residentials.
You heard us maybe talk about this during our BAA. We targeted the micro residentials specifically because oftentimes those are folks who tend to have a difficulty hiring, and specifically the overnight shifts, and it serves our youth. It's a highly utilized program for stepping out of the hospital or past hospital.
Well, we haven't kept you to your script.
That's
Do you
okay.
do you want us to go off the presentation and maybe just ask us questions
Well,
around
I
the
think
different?
so.
Okay, that sounds
I
great.
think so. Senator Lyons, I just want to make sure that if you have any questions, we give you an opportunity.
I'm very good. I will put my hand up
Okay,
and thank you.
all right, just wanted to make sure. We sometimes forget if you're not in the room, but you're still here. I don't think,
I'm here.
but I don't think Senator Sears joined us. He hasn't been feeling well, so I can understand that. One of the areas that we're getting obviously a lot of attention, and that is mental health needs, particularly of adolescent girls. And how does that at all fit in in terms of your work or what you see in terms of demand for services? And
Sure.
what has been kind of the response, or what do you anticipate needs to be done, or would you recommend needs to be done?
Sure. So, and we've seen that in our data as well. And I believe, especially with folks experiencing disordered eating. So that is certainly something that we've also been engaging across stakeholders on what folks think would be most beneficial to have as a part of our system to serve that particular group of folks. When you think about our mobile crisis program and initiatives, those are opportunities to serve and assess folks within the school system. So that's one level of care. When you think about our alternatives to EVs, you're also giving an option of somewhere else to go besides an emergency room. And then also from an inpatient perspective, we know that there's an increased need in adolescents for the highest level of care too, which was why you saw that in our BAA to increase capacity related to adolescent from an inpatient perspective.
On the news a few days, I think it was last week, that actually in the Burlington area, that there is now a clinic or a program, I guess a program that specializes in eating disorders. And there was a woman with her teenage daughter who testified and had sought out treatment, had even gone to Massachusetts to a special program without success. And obviously the daughter was getting increasingly ill and debilitated, and finally has gotten stabilized. Is that a service that would be reimbursed? Is that something that maybe not mental health, but is that something that
It falls under the DIVA
That would
reimbursement, so
fall
they've
into the-
typically been the lead, especially with that. But there have been resources in the Chittenden County area for quite some time for youth to access who have eating disorder.
Well, apparently,
So it's-
what had been provided
Yeah,
wasn't
so it's good
working.
that that's maybe shifting and growing because we are seeing that as a need, but that benefit comes under DIVA.
Senator Lyons has a comment.
Yes, Senator Lyons?
Yes, so this is really very related very much to my previous question around the use of the small little amount of $3 million that we put in last year. Obviously, adolescents spend a good deal of time in the school environment, and their teachers and counselors understand some of their needs sometimes more than parents do. And I'm wondering how we can continue to track the work that's going on with those grants. I don't want to beat a dead horse with this, but I know that the after school program has been so significant, providing mentoring and one-on-one support for kids, particularly adolescent girls. So I think that this becomes more and more important as we go forward, and ensuring that we see not just the day-to-day support and friendship, but also, and those, building those relationships. But beyond that, to a greater extent, the psychotherapeutic needs that schools can provide by having, these grants in place. So I would just encourage, I know you're probably way ahead of me on this one and collecting the data, but I wanted to reinforce that because it's not one or the other. It's these things all go together. You can't just say, adolescent girls are having problems, and so we need community resources. Adolescent girls are having problems, and they're very much embedded in the school system. So that's just a comment. So.
Okay. Thank you. I guess, in other words, the one thing about the connection with the DAs, and if they have, as opposed to hiring, schools hiring their own clinicians, is that they've greater resources. So they generally have a medical director. There's oftentimes they have a psychiatrist or access to a psych. So often times it's good to have that level of expertise and backup to go with that individual, which, a single individual, not to say that it can't be done. Certainly there are a lot of independently practicing clinicians and so forth, but within that structure, oftentimes it's great to have someone that you can consult with and oversee the work that is there. And obviously, Success Beyond 6 is a big item here, $72 million in terms of the payment out to services in that school setting. And it's actually, well, I guess it's your second largest after adult services CRT. So Mobile Crisis is about to be launched in the fall, I guess is what you're saying.
Yes.
And to go all areas of the state. You've done RFPs and
The fall is 5 regions. We want to expand to 10. So we did put an RFP out that is closed, and we're getting ready to do notice of award. And we had one bid response to that.
pardon me,
We had one bid response to the RFP.
Well, that's not an enthusiastic response, is it? Well, unless it's for the entire state. And,
It was, yes, it was.
Maybe it is, if it's like,
It was Vermont Care Partners.
Yeah, I was gonna say, if you're actually putting together one that in fact, a coordinated response,
Correct.
there's a lot to be said about that.
Yes.
Well, that makes more sense then, as opposed to a single agency.
Yeah.
Because we do have, the Southwest Hospital, where there was only one response to your RFP?
And we posted that RFP twice. So there was one response when we first posted it, and that was the UVM Health Network.
Yeah, I know.
And then they pulled their commitment from that. And so we posted it again, and Southwestern Vermont was a provider that came forward. And we are still in the feasibility study of that initiative.
When is that gonna be complete? We've deferred that until the 24 budget, and that's part of why I'm
Yeah.
raising it. What's your timetable for that, even the first step of feasibility study?
I think the deadline is March 31st. And we're meeting regularly with them throughout their study. So we'll know more.
Yeah, before we adjourn this one.
Yes.
Other questions? Well, I think then, the materials all here. I think this is not a committee where we have a lot of long-term experience, and so
Yes.
I think some of the House committee, where they've got so many new members, and many of them new, even to the legislature, probably takes a bit more time, or they want more detail than perhaps we're asking of you.
I'm happy to talk more about salary for and travel nurse plans for the hospital, if that's something this committee would like for me to talk more about, since those are a large cost. Whatever you would find helpful.
Well, we've got a solution to contract nurses. I guess we would like it, because it certainly is a cost.
It
It's being
is,
experienced throughout the care delivery system. I got a note from an adult day provider, and they can pay only their LPN $15.50 an hour.
Mm.
And they're like saying, we're not even able to compete.
yeah,
So,
difficult.
yeah, and so we've been obviously pumping in a lot of money to the state facility, but the experience and the costs are not limited.
Yeah, we are hopeful that some of the initiatives that we put into place over the last year are impacting in a positive way. I'll give an example. We have a series of positions called mental health specialists. There's an entry level, an associate, and a senior. You used to have to come in as an entry level and work your way up internally. We've shifted that to allow us to hire into an associate, hire into a senior based on someone's experience, instead of needing them to go through. And I think since we've done that, that went live a couple of weeks ago, we did receive 12 applicants. And we haven't had 12 applicants in a year. And so we are seeing some positive movement in some of those shifts. It really forced us to relook at how we define who's qualified to be doing the services that we deliver. And I think that's probably what all healthcare systems are really looking at. So that would be one highlight that I would just put out there.
A strategy that you think is gonna.
So far, it's 2 weeks old. I won't get too excited, but.
Wondering about the quality of care though. I mean, they're being trained on the job.
So we offer on-site training. We have an education and training program that will do a small bit of classroom and then a preceptor program. So folks are assigned another staff member. But when we're opening it up for folks to apply and get hired into an associate or senior, they're already coming with some experience, and we're being able to honor that experience and get them right into our onto the board.
Well, thank you.
Yes.
Obviously, as we pour through things, we'll be, I'm sure, following up.
And we're happy to come back. Deputy Crump is very good at talking through the data in a way that shows that the decisions that you're making are impacting Vermonters in a positive way. So I'd love for an opportunity to come back for us to talk through that if you have any further questions.